I'm Ken Altman, Director of the Institute for Voice and Swallowing at Baylor College of Medicine. I'm here to talk about chronic cough. One of our programs is in our collaboration with the pulmonologists, the gastroenterologists, and speech therapists to deal with patients with chronic cough, which is cough that lasts longer than 2 months and is unremitting despite any obvious known cause. The first thing I want to leave you with is that if it's a non-productive cough or even a productive cough over the last 2 months, the first step, according to the chest guidelines, is to get a chest x-ray, and if they're taking an ACE inhibitor, they need to stop that. The workup for chronic cough is multifold. It really starts with a good history and understanding the leading contributions to chronic cough, and that includes rhinologic causes, respiratory or lower respiratory causes such as lung disease, and also reflux disease, which is an uncommon cause in the absence of heartburn or regurgitation, but it could certainly still be present. It's okay to diagnose cough based on an empiric history and your findings on a physical examination. But if it persists despite your empiric treatment after about a month or so, you really do need objective data to show that you're really treating a disease rather than your own suspicion. In other words, you need an objective finding on an objective test such as nasal endoscopy, bronchoscopy, chest CT scan, sinus CT scan, and esophagoscopy with pH probe in order to prove the causality of those diseases with the cough. The American College of Chest Physicians has come up with an exhaustive list of guidelines in how to manage cough for some of the less common etiologies. These include unexplained chronic cough, habit cough, which is now considered somatic cough syndrome, tick cough, as well as neurogenic cough. It's sometimes really challenging to distinguish between the somatic cough disorder, tick cough, and neurogenic cough. And it's very helpful to have a speech pathologist to understand what the causalities are to the initiations of cough, as well as how you can treat it. Most importantly, at this point, once you've ruled out the fact that there's an underlying disease that's really bad and is going to hurt the patient with time, you can actually be more focused on supportive care for the patient. That way they can get through their life, enjoy their day, and actually suppress the disabling qualities of the cough. Once again, I'd like to reiterate that you really do need objective data to show that patients do not have suspecting disease in the nose, in the chest, and in the esophagus contributing to the likely causes of the cough. And sometimes that also requires a CT scan of the neck and chest. Supportive care for the chronic cough has to do with speech therapy to desensitize the larynx stimuli that contribute to the cough. And there are a host of medications that are also used for suppressing the cough threshold. Some of the patients that I see are quite challenging, and I think the challenges have to do with, number one, how the primary doctors have addressed this patient in the community. We really have to do a better job in communicating to them about how we're caring for their patients from a specialty standpoint, and also about what the basic chest guidelines say, and that is, for 2 months of a chronic cough, they need a chest x-ray and to stop their ACE inhibitor, of course, replacing it with something else that's necessary for their underlying high blood pressure. I think the take-home message that I'd like to leave you with is that it's important to communicate with the primary doctors that are ultimately responsible for these patients in the long term. And it's also important to find your team of gastroenterologists, partners in pulmonology, allergy, and your team of surgeons and speech therapists that you can all connect with. Find good people and work with them.